So I would like to welcome you all to this session today on Practical Guide to Diagnose and Control Leprosy in General Practice. So this CPD session was organized by the CPD Committee and Communicable Disease Subcommittee of the College of General Practitioners of Sri Lanka. I would like to thank Dr. Chidambaram Shanmugasundaram and Dr. Iranthi Valgampaya from the CPD committee for setting up the CPD points for this session. And also I would like to thank Ms. Dimutu and Ms. Nimmi for giving up the technical support. And a very special thank you to Dr. Pushpa Veerasinghe, the President of College of General Practitioners of Sri Lanka. Before we go ahead, I want to just touch on a few housekeeping rules. Please mute when not speaking. And also you can put up your questions in the chat box. And also if the speakers allow you, you can ask the questions in between by unmuting your mics, or else you can ask the questions at the end of the session. So today's session will explore various dimensions of leprosy, from clinical presentation and diagnosis to treatment. We are very fortunate to have with us a panel of experts who bring deep knowledge and field experience in managing leprosy. I look forward to the insights they will share with us today. Today, as our first speaker, we have Dr. Dilini Vijayasekara, MBBS, MSc, MD in Community Medicine, consultant community physician with over 20 years of experience in public health. She is spearheading the anti-leprosy campaign from the Ministry of Health. Over to you, madam. Thank you very much.
So thank you, Harun. So what I will do is I will brief you what is the importance of knowing on leprosy as a general practitioner, why you should know of leprosy. So afterwards, you will learn the clinical presentation and how to manage those things by our consultant dermatologist from the anti-leprosy campaign. To start with, I think it's better if I give you some I will show you two case histories. The first one, this one is a 19-year-old boy from Kimbulapitia. He had a chronic ulcer for 6-month duration, and he has seek treatment from several doctors. And afterwards, he has admitted to TGH Nigambo with a wood stick injury. And this is the boy. You can very well see his backside. And at the time of presentation, he had a foot drop also. So afterwards, from the hospital, he has referred to the dermatology clinic and diagnosed as having leprosy. Now, keep it in your mind, this one is with the age of 19 years. So the next one, just see this, this male is 38-year-old one. He has had a kind of a numbness on his right foot and has developed an ulcer in his big toe. And for 2 years, he has been going here and there and looking for treatment. And ultimately, one general practitioner has seen this one, has referred to the National Hospital. And from the National Hospital, actually, he was referred to the plastic surgery unit. Then from the general hospital, he was sent to our central leprosy clinic and he was diagnosed as having leprosy. So this one also has visited several hospitals, including national hospitals, some general hospitals, and has seek treatment from several doctors also. But it has taken 2 years to diagnose this one as having leprosy. So these two cases will very well show you how this happened in Sri Lanka. As we all know, we have eliminated leprosy as a public health problem in 1995. But still, we are having a lot of cases. These kind of cases are reporting day to day. So therefore, it's of importance as general practitioners to know what is happening in the country. So if I to tell big, it affects the skin and the peripheral nervous system. Because of the involvement of the peripheral nervous system, a fraction of people, a percentage of people would end up like this. So from our data at the time of starting treatment, that is the multi-drug therapy, around 7 to 8% of our people are having some form of deformity. We call it grade 2 deformities at the time of starting treatment. So it's pretty much important as doctors to aware about this situation, because some of these deformities we can't revert back. So the person who was affected with leprosy, if he was with kind of deformity, sometimes we may give physiotherapy, but sometimes these deformities and the resulting disabilities are lifelong. So the other thing, unlike in other diseases, as we all know, nobody wants to have leprosy. Therefore, we do have a stigma, and all those persons who are affected with leprosy, from the society, they are tend to discriminate these people. So when we are working as doctors, these things we need to keep it in our mind. If I rush into the, the national level data, as doctors, we should know how many are we are identifying from the country and those kind of things of importance. So in 2024, we were able to identify 1,350 patients. Out of these 350 patients, 91 were below the age of 15 years. So leprosy can get anyone. As a percentage, it's something around 7. So the grade 2 disabilities in leprosy, if a person is having some form of visible deformity, maybe the person would be having some form of deformities in his eyes, maybe his upper arms, lower limbs, we would be calling them as having grade 2 deformities. In leprosy, we do have something called grade 1 deformities also. If the person is having some numbness kind of things, as doctors, we can't see those things. So those people will be classified as having grade 1 deformities or disabilities. So in our country also, like in the globe also, this scenario is the same. The majority who are with leprosy tend to be males. We do not know what is the reason behind. And the other thing, last year we had 24 patients. They were defaulted from treatment, and we were able to catch up those people, and we have started treatment again. So as general practitioners, these things you should know, because you will be encountering people who were started with MDT, and as because of the long term treatment, people tend to default. So please keep these things in your mind. So to tell you a bit on the epidemiology of leprosy, we identified majority of the patients from Western province plus Eastern province. Annually more than 50% of the patients we are identifying from these two provinces. Apart from these two provinces, from down south, Galle, Matara, Hambantota, and northwestern province, Putlam Kurunegala, North Central Province, that means Anuradhapura Polonnaruwa, majority of the patients we are identifying. So this thing I have told you, and anyone can get leprosy. If you could see this in this slide, we have analyzed few years data. In there, we have seen this is the age distribution of our people. You could very well see the age group of 25 to 35, 35 to 44. Those are the people who has had leprosy more. So those are the people who are the economically active population in a country. So even though leprosy could not kill a person, this is the gravity, and this is the problem at the moment we are facing, because year by year people will be end up with deformities and disabilities, and ultimately they will be dependent of our community. So even though we can't see, it's kind of in numbers you could see only the tip of the iceberg, but the major part lies inside the sea. So therefore, even though we are not thinking about this disease as a major communicable disease, um, the impact to the community or the society as such. Therefore, we need to consider about this illness. So this is the last slide I'm going to show you. This shows the delay in diagnosis in leprosy. in our country. You could very well see here also we have analyzed previous data from our campaign perspective. So you could very well see 47.2% of our people were being correctly diagnosed within 6 months of the first initial clinical manifestation of leprosy. That is good. But concentrate on the last part, 25 months or more, 18%. That means 1/5 of our people who were with leprosy were being diagnosed 2 years after the first clinical manifestation. So this is why we were not being able to interrupt the transmission. This is why in our country, child leprosy cases are such, the percentage of child cases are high, and this is why we are having lot of people with grade 2 deformities plus grade 1 disabilities or deformities in our country. So I think basically you should know a little bit of these things. And apart from that thing, basically what you have to know the clinical presentation. I think you now very well know what is the situation and why you are an important person in diagnosing in leprosy. So I am asking and urging you to keep leprosy in your mind when you are next seeing a patient with a skin rash, because you might not know, knowing because of we have eliminated leprosy. More often we might not think of leprosy when you are seeing a skin patch. So thank you very much. And Dr. Chaturya, the consultant dermatologist, will tell you more about leprosy, clinical manifestation, diagnosis, and treatment. If you do have any questions after his sessions, we can discuss. Thank you very much.
Thank you very much for that insightful talk, madam. So, as our expert, the second expert on our panel is Dr. Chatur Arya Sirivardhana, MBBS, MD in dermatology, MRCP UK, FRCP Edinburgh. He worked as a consultant dermatologist at the Ashford and St. Peter's NHS Foundation Trust in UK until January 2025, and is currently working as the consultant dermatologist at the Leprosy Clinic at the National Hospital of Sri Lanka. Over to you, sir.
Thank you very much, Harun. I hope you can hear me. Is it clear?
We can hear you loud and clear, sir.
Right. So, leprosy can be quite a confusing topic because it has a wide array of clinical manifestations, and its pathogenesis also is a bit complicated. So, it can be quite challenging to diagnose, sometimes even for us. So, what I thought is we'll go through some very basic principles and salient points for us to try and identify some features, and hopefully that will help us in the rest of our presentations when we go through some pictures. Right, so I'll try sharing my PowerPoint. I hope you can see my slide now.
Yes, sir. Yes, sir. We can see it now,
We
sir.
can. Great. So basically, moving on. Just give me a second. Yeah. So what is leprosy? Leprosy is actually a chronic infection caused by gram-negative bacillus called Mycobacterium leprae. And of recent, a new organism called Mycobacterium lepromatosis has also been identified. It is primarily a disease of the peripheral nerves and skin. But having said that, it can affect all organs except the central nervous system, that is the brain and the spinal cord, the lungs, and the ovaries, right? As you can probably see in this picture, you can see some nerve fibers in a wavy form at the bottom, and you can see these red rods. Those are actually the lepra bacilli, right? So a little bit more about this organism. It's an obligate intracellular parasite. So the conventional antibodies which work against bacteria don't work here. So we have to rely on a cell-mediated immune system, just like for viruses and cancer cells, to get rid of this organism. Now, it has a predilection for skin adnexal structures and Schwann cells. So I'll talk about skin adnexal structures in a minute, so don't worry about it. Also, it prefers a temperature of 32 to 34 degrees centigrade. The importance of this is that is a little bit cooler than our core body temperature. So that's why most of our skin lesions occur in areas like the limbs, earlobes, nose, and you rarely see lesions in the axilla, groin, scalp, or midline of the back. And also, unusual for a bacteria, for one organism to become two, to divide by fission, it takes a long time. Now, normally a bacterium within a few hours, it goes from 1 to 2, 2 to 4, 4 to 8, so on and so forth. But for leprosy, for that to happen, it can take anywhere from 12 to 14 days. As a result, the incubation period is very long, from 9 months up to 20 years. So once the organism enters our body, to develop clinical features, it can take that long, from 9 months to 20 years. So this has a lot of implications. Obviously, screening for household contacts, and as well as to detect the disease following infection. Usually this is spread from untreated infected humans. Now, as you go along, we'll see that there are leprosy is like a spectrum. At one end, you get patients who have it like a localized disease, and at the other end, it's a systemic disease, and they have a high bacterial load. And that group of patients, whom we call lepromatous leprosy patients, are the ones who spread the disease. And also, it's very important to note, not everyone who gets the bacterium into them gets the disease. 95% of us have immunity to eradicate this before it develops into the overt disease, right? So that is quite important. Only 3 to 5% will go on to develop clinical symptoms. So we'll just start a little bit on the skin anatomy. So I told about skin adnexal structures, didn't I? So the adnexal structures in the skin are the nerve ends, the oil glands which produce the sebum, or the sebaceous glands as they are called. They help to keep the skin moist. The hair follicles, the sweat glands which produce the sweat. And also, if we look carefully in our epidermis, we see there are melanocytes which produce the melanin, or the pigment of the skin. Now, this is relevant because now leprosy, or any disease for that matter, it's like a war between our immunity and the virulence of the organism, right? So, and in any war, there can be collateral damage due to the inflammation. So when these organisms are in these adnexal structures, there is inflammation and damage to these sites. So when the nerve ends are inflamed, you get, in the early stage, hyperesthesia, where the sensation is more, and at the later stages, you get anesthesia, touch, temperature, and initially to pain and temperature. Then when the oil glands are inflamed and destroyed, the sebaceous glands, the skin becomes dry and scaly over these lesions. And damage to the hair results to the loss of hair, right? So, for example, you can lose your eyebrows, we call it madarosis. And obviously, damage to the sweat glands leads to anhidrosis, or loss of sweating. Melanocyte damage will lead to hypopigmentation. That's why you get hypopigmented, anesthetic, dry, scaly patches, sometimes with absence of sweating and loss of hairs. So the more intense the immune response, the more likely to, you see these features within the patch, right? So how do we get the disease? So speaking briefly on the pathogenesis, as I said, it's from an infected lepromatous patient, or a multibacillary patient as we call it, from their nasal and respiratory tract secretions. Once we inhale it, and if we don't have the proper immunity for it, our alveolar macrophages take it, and it's disseminated through the blood to the nerve and the skin. And they proliferate in the Schwann cells and can go on to produce the disease. Now, in a majority, as we said before, the natural resistance will clear it off. In some, it will go on to, they will go on to develop symptomatic leprosy. And again, in another minority, they can get like a vague patch. There can be vague sensory loss or no sensory loss, like a vague solitary hypopigmented patch. We call it indeterminate leprosy because at that stage, you can't identify leprosy accurately often. And even if you do a biopsy, it's not very convincing. And with time, it can clear completely with the immune system, or that also can go on to develop symptomatic leprosy. So the clinical features of leprosy, depending on our immune response and the virulence of the organism, is like a spectrum, right? So that's what you see at the bottom, TT, BT, BB, BL, and LL. So at the left end, we have what we call tuberculoid leprosy, where we have a good cell-mediated immune response. And at the other end, we have lepromatous leprosy, where we have a poor cell-mediated response and a good antibody response or a humoral response, which is not effective. So tuberculoid leprosy is more like a localized disease, whereas lepromatous leprosy is a systemic disease. And in between the spectrum, you have mid-borderline, and then between tuberculoid and mid-borderline, you have borderline tuberculoid. And between mid-borderline and lepromatous, you have the borderline lepromatous. So when you move towards the right, you have more and more skin lesions, more and more bacteria, leprosy bacteria, more and more antibodies, right? Because our immune response is not effective. Towards the left side, skin lesions will be 1 or 2. They'll be very well demarcated. And within this, you won't see bacteria basically. And it might be quite inflamed. And within this, there can be anesthesia and hypopigmentation and loss of hairs because it's a more inflammatory state because we are mounting a good immune response and more collateral damage. I hope it's clear so far, right? And nerve damage can occur at any of these stages. So moving on to the clinical features, right? So the earliest, as I said, some people, when they get infected, can move on to this, what we call indeterminate leprosy. It's a very transient phase where they can come with 1 or few hypopigmented patches with vague sensory loss or no sensory loss, commonly on the buttock, face, or thigh. And it either resolves spontaneously and the patient is cured, or it moves on to that spectrum to develop either tuberculoid leprosy or lepromatous leprosy or anywhere in between. So this is a very transient stage. So at this stage, it's very difficult to diagnose. So moving on, you have the tuberculoid leprosy, which is very localized and stable. There's a good cell-mediated immunity, and there's a well-demarcated margin. And we spoke about these clinical features. And sometimes they can have a solitary nerve trunk thickening or none at all. And the smears will be negative. So when we scrape this, when you take some tissue fluid and stain it, we won't see bacteria in it. So here are some more pictures, well demarcated. You note it doesn't go into the scalp because the hair acts as an insulation and it's warm. And the good vascular supply makes a higher temperature. So usually you don't get leprosy in the scalp. So here you see a lesion on the middle finger resulting in diffuse inflammation or a sausage digit, which we call dactylitis. Right? You can see it's hypopigmented and fairly reasonably well demarcated margin. Here again, a reasonably well demarcated lesion on the eyebrow with loss of the hairs due to the inflammation. Sometimes it has what we call a coppery color. Now in children, it doesn't always have to be hypopigmented. Sometimes, especially smaller children, they feel a sensory impairment, change in the sensation. So they are always touching it, picking on it. So you might see hyperpigmentation or excoriation sometimes on the lesion because the child is constantly picking on it. Right? So it can even be hyperpigmented sometimes. So moving on the spectrum, when your cell-mediated immunity is a little bit less, the lesions can be larger. You may have about 2 or 3 or larger number of lesions. Margins are less well demarcated. It might have like pseudopodia where it's trying to bud out, out of the main lesion, or you might have satellite lesions, and you might have evidence of peripheral nerve thickening, asymmetrical nerve thickening. So here is another lesion. You might see there is a hypopigmented patch involving the little finger. And what is that lesion in the middle, that black scar-like thing? That's actually a burn because of the sensory loss, right? So that indicates that this is anesthetic. Right? Sometimes in your practice, you might see patients coming with multiple blisters on the hands and the digits due to repeated burns. So if you get a patient with repeated scarring or various blisters at different stages of healing on their hands, don't forget they might be having a sensory loss. Maybe leprosy or maybe a rare thing like syringomyelia or whatever. So just keep an eye if you get a patient with blisters or multiple scars on the digits. So here are some more lesions. You can see there are larger, less well demarcated, might be scaly, dry. And these often can be associated with thickened nerves near the vicinity of the lesion. So on the left, you can see a lesion near the jawline going right up to the ear. And there's a visible thickened nerve. And on the right also, you can see a thickened nerve that has been arrowed. More often than not, you can't see thicker nerves. You have to palpate and feel for it to find it. They feel like firm cords, really. So mid-borderline is the next group. That's an unstable form because right in the middle, our immunity hasn't evolved to one direction or the other. And they come with this typical inverted saucer-like appearance. That is like a paresia, copoparesia. When you turn it upside down, there's a central punched out area, depression. And from there towards the periphery, it's gradually slanting outwards. So here also you can see a punched out lesion slanting outwards, less well demarcated. So here you see another one and another one, more larger lesion. And you can see more and more lesions when you're going down the spectrum, when your cell-mediated immunity is less. And the lesions are also larger. So going on further towards the lepromatous pole, now your cell-mediated immunity is not good. So here lesions are more and more less well demarcated. You can see it's all over the trunk, but still somewhat asymmetrical, not symmetrical all over, right? And they can have anesthesia and paresis. And often when you do a smear, these patients, you will often identify bacilli, leprobacilli. In between the lesion, the skin is normal. You can see normal areas. So even in these, there is a wide spectrum. Some people can have lots of lesions. And you can see the lesions on the left, you can easily mistake them for pityriasis versicolor, isn't it? Other patients might have more prominent lesions. You can see, in addition to the lesion on the back, the patient on the right has lesions on his upper limb. If you look very carefully towards the edge of the foot, you can see lesions on his upper limb as well. So it's more and more systemic, but somewhat asymmetrical in distribution. Another lady, you can see a lot of lesions, and they can spare the midline, as I said before, because the temperature is a little bit higher towards the midline. You can have asymmetrical lesions. You can see how different the clinical manifestations can be. So in these lesions, sensory loss may be more vague because there's less damage by our immune system. They will have a sensory loss, but it might not be very well demarcated. And they may be less inflamed. So you can get these dry, scaly patches all over. Again, it might spare the midline. Then at the other end of the pole, when the cell-mediated immunity is not satisfactory at all, you end up with lepromatous leprosy. So they have a lot of antibodies, circulating antibodies, but it's not effective because this is an intracellular organism, isn't it? So antibodies are not going to work. So they can have diffuse infiltration of the skin. They can have nodules, and often these are ill-demarcated. And infiltration of the eyebrow area will result in loss of the eyebrows because, as I said before, the hair follicles are damaged. And often they will have lots and lots of bacilli. The nose becomes flatter and broader, and they have diffuse infiltration, and they look more and more like a lion. So it's called a leonine facies. They can also have swelling of digits, which you call dactylitis. So lepromatous leprosy is a systemic disease. So it can affect most organs in the body, as we said before. They will have nasal congestion, epistaxis, and the nasal secretions will spread the disease to the others. Cartilage damage will result in a saddle nose, and mucosal involvement can happen in the larynx and the oropharynx. They'll have a symmetrical peripheral neuropathy, and nerves may be thickened, but not to the degree of the tuberculoid pole. And sensory loss may be vague because our immune system is not that effective, right? And eye involvement they can have glaucoma, lagophthalmus, uveitis, corneal opacities, keratitis, exposure keratitis, blindness, so many things. Testicular atrophy, infertility, and as resultant gynecomastia, glomerulonephritis, amyloidosis due to the circulating antibodies and antigen antibody complexes, bone resorption, and shortened fingers and toes. So we'll see pictures as we go along. So here you see the flattened nasal bridge, a saddle nose. Say saddle nose you can see in so many other conditions, congenital syphilis, vaginous granulomatosis, so many things. This pigmentation you see is the effect of the drugs. We give a drug called clofazimine, which is actually a dye. It gives this typical mahogany brown color. So if you see a person walking on the road with this color, you can be certain he has been treated with clofazimine. It's not a permanent thing. Once the drugs are stopped, once the patient is cured, within 1.5 to 2 years, it is cleared completely. So you can have diffuse skin infiltration. And sometimes this may be actually to the patient's advantage. I'll show you in a minute. So you can see how difficult diffuse skin infiltration can be to diagnose. It's very vague. Now, if you look at the picture on the right, I don't know if you can see it clearly. There is a vague hypopigmented area towards the medial side. It's very vague because the immune response is not gating it to a particular area. But towards the edge of the lesion, you might see beads of sweat, right? There is sweating in the normal skin, but within the lesion, there is no sweating. So that anhydrosis is a clue. But if you do a smear, they will have a lot of bacilli in this. So I said diffuse infiltration of the skin may be to one's advantage. This is actually called lepra bonita. That means pretty lady. The reason being, when the skin is diffusely infiltrated, the wrinkles of the skin are lost, right? So these patients look younger. We have so many patients undergoing cosmetic procedures with fillers, Restylane and collagen to look younger. And here, the leprosy itself is causing a diffuse infiltration, resulting in a younger look. But if you look carefully, the patient has lost her eyebrows and she is using eyebrow pencil. Unfortunately, when you treat these patients, the wrinkles appear and they appear in their natural age. So they won't be very happy. So you can have nodular lepromatous leprosy where they get skin nodules, right? Here is another patient with nodular lepromatous leprosy. You can, however, you can even mistake it sometimes for acne, isn't it? You get these bumps, but unlike acne, they are long-lasting and persistent. And here there's a clue that the patient has had ear involvement. Actually, this patient had been mistaken for erysipelas because of the ear involvement. Usually, if the ear is involved in infections, since if you consider cellulitis and erysipelas, you don't get cellulitis in the ear because there is no subcutaneous tissue. And that helps to distinguish erysipelas and cellulitis. But in this patient, it is actually leprosy. So you can see how easy it is to miss. Another rarer variant is what we call histoid leprosy. Now, they come with skin bumps. You can see a typical histoid lesion on the earlobe. They are flesh-colored to slightly red-colored bumps. They also can look like pimples, but they are persistent and they are teeming with bacilli. They are highly smear positive and they are highly infective. So here you see some more histoid lesions. They're pink-colored to skin-colored nodules on the skin. You can also see similar lesions on the foreskin because again it's a acral area and a cooler area of the skin. So another variant we might see is what we call pure neural leprosy, where they don't have skin lesions. It just affect the nerves. So 5 to 10% of leprosy patients have only lesions in the nerves, and they don't usually come to us. They go to the neurologist. So since this slide has been produced, the management has changed a bit. So even if you have one nerve involvement, we go for more intensive treatment, right? So I'll just go on to the complications of leprosy. So one of the commonest complications we see in leprosy are what we call lepra reactions. These are immune reactions to the organisms, right? So we talk about a type 1 reaction, type 2 reaction, which we call erythema nodosum leprosum, and very rarely what we call Lucio phenomenon. So I'm not going to dwell much, but the significance of these is unlike the typical leprosy lesions, which develop over months to years, these can occur overnight, right? So that you need to keep in mind. So a type 1 or a reversal reaction occurs when a patient's immunity goes up, it's upregulated or goes on the turbo. So for some particular reason, either after viral infection or anything, your cell-mediated immunity goes up. So previously, if your patches were flat, slightly anesthetic, they suddenly become red, inflamed, elevated, and patches become like plaques. You can come with acute nerve palsies. Now this patient can come with difficulty in closing the eye due to the nerve inflammation, right? So that's due to the upregulation of the immune response, which is in a way a good thing. But due to the risk of nerve palsies, we usually manage this with steroids, NSAIDs, because it can lead to nerve damage. So again, another patient, flat lesions become elevated and red and inflamed. So type 2 reaction is due to circulating immune complexes. And this, as a result, is more common in lepromatous leprosy, unlike the former ones, which are common in the borderline groups. So they come with subcutaneous nodules, which are especially on the lower limbs. It's similar to what we call erythema nodosum, which is again due to circulating immune complexes, and which also comes with subcutaneous nodules. But in this, the lesions are smaller and they ulcerate and can involve the upper limbs, unlike conventional erythema nodosum. They are more transient, small lesions which ulcerate, and where they can be associated with fever, glomerulonephritis, arthritis, and so many things because of the immune complex deposition, right? So it's another patient with erythema nodosum leprosum. It can be very subtle and you can even mistake for insect bites. But unlike papular urticaria or insect bite reactions, which are very itchy, usually these are not itchy and they will have other cutaneous stigmata of leprosy. And rarely we have this Lucio phenomenon where you get necrotic skin. It's not usually seen in our countries, but it is life-threatening and can kill. Another complication is neuropathic ulcers. They can come with other cutaneous manifestations of leprosy or in pure neural leprosy without any other skin manifestations. The importance of this is commonest cause of neuropathic ulcers is not leprosy. What is it? Huh? It's diabetes, isn't it? Diabetic neuropathy. So in your practice, if you come across a diabetic patient, relatively young, had diabetes just for 1 or 2 years, but reasonably controlled, no other complications of diabetes, coming with a neuropathic ulcer, just be certain it's due to diabetes and not due to leprosy, because both can coexist, and we have seen that happening sometimes. So just because you get a neuropathic ulcer in a diabetic, it might not always be diabetes, right? You can come with a foot drop due to the damage to the posterior tibial nerve. And if you look carefully, so this patient can't dorsiflex the foot, so it can be partial or complete. So he can't dorsiflex the right foot unlike the left. And if you look carefully, they might have damage to the, the base of the toe on the dorsal aspect due to the toe hitting the floor. There can be damage to the nails when the nail is rubbed against the floor when they are, have this foot drop walk, isn't it? They can walk with the foot rubbing on the floor. It has a typical gait. And they can also be associated with thickening of the peroneal nerves as well. Sometimes they might come, especially they come with a history. The foot drop may not be apparent. It might be just a mild weakness of dorsiflexion, but they might come and say the slip serapua visienova. They say serapua visienova. The slipper comes off when they are walking. That's due to the weakness of the small muscles of the foot. So that is also a clue whether that there is some kind of nerve damage, right? Or at least small muscle damage. So think of leprosy, okay? And they also can come with clawing of their hands or feet. So this is a claw hand due to leprosy. It obviously it's disabling. So we don't want to detect patients at this stage. We want to detect them much earlier when they come with nerve weakness, because an established claw hand causes a lot of disability. So these are typical ulnar claw. So as I said before, they can come with sensory neuropathy. So they can come with multiple blisters, like the patient on the left. They say, "Uinakota pichuna," especially housewives come and say they got burnt when they were cooking, right? But if you get multiple blisters, various stages of healing, think about the possibility of a neuropathy, right? And also autonomic neuropathy also is common. We might miss it sometimes. They come with bilateral lower limb swelling sometimes, right? You can see the pitting edema here. The sleeper strap is depressed, isn't it? So they come with lower limb swelling, and you can see the dryness of the skin due to the features of leprosy. They come with ichthyosis and dry skin associated with this. So this swelling is, so if you find a patient with leg swelling, no liver, renal or cardiac cause, no other cause, no hypoalbuminemia, just wonder whether it could be something like an autonomic neuropathy, and leprosy is one of the common causes of that. So due to repeated trauma and autonomic reflexes, they can have bone resorption and digits become shorter and shorter. So we say in leprosy, angili helena කියනවානේ, digits fall, but actually they don't fall off. They are resorbed, right? So the digits become shorter and shorter, which can be quite disabling and lead to considerable stigma. Lagophthalmos is another complication due to damage to the facial nerve and resultant paralysis of the orbicularis oculi. As a result, it can lead to exposure keratitis, corneal scarring, and blindness. So eye manifestations are much more than this, but I'm not going to talk all about that. There is no time. And we spoke about this as well. So this is what we don't want to see in our clinic when we have missed the bus, right? So we don't want to come to this level. You can see there's corneal scarring, blindness, thickening of the eyelids, madarosis, and nasal damage, loss of the nasal cartilage, isn't it? Loss of dentition. So at this stage, it's really disabling and they are totally dependent on others. Often these patients we find at the hospital where they have been discarded by the family members. So it's very sad. Another complication that needs urgent treatment is what we call nerve abscesses. This is common with the type 1 reaction or the reversal reaction when your immune system goes on the hyperdrive, right? So suddenly you have a lot of inflammation around the nerves that are infected with Mycobacterium leprae, and they form abscesses. Now the problem with abscesses is it can lead to pressure effects, especially in the ulnar groove. If you get an abscess there like the lesion on the left, it compresses and causes ischemic damage to the nerve, right? And that would result in a permanent clot. The patient also has an abscess, I think, in the palmar-cutaneous branch of the median nerve. Now, so these are emergencies. If you don't treat these urgently, the patient is going to lose the function of the nerves and the upper limb, obviously resulting in disability. So these are treated with urgent oral prednisolone, high dose prednisolone. So although we call it an abscess, we have to treat with high dose prednisolone, and even with nerve incision and drainage to relieve the pressure. Sometimes we might add oral antibiotics as well because we are giving high doses of prednisolone. So diagnosis of leprosy. So usually it's a clinical diagnosis and they should have a hypopigmented or erythematous skin patch with definite partial or complete loss of sensation. Especially on the face, just don't buy loss of sensation to touch because the rich innervation, it can be present and you might only have loss of sensation to pain and temperature. Also, they might just come with thickened peripheral nerves, or they might have positive slit skin smears for acid-fast bacilli. So these are the confirmatory features. So as I said, it's primarily a clinical diagnosis, but adjunct, we use slit skin smears, skin biopsies, nerve conduction studies, which may help. So differential diagnosis, I think as a GP, this is what's important to you because you all won't be diagnosing and treating leprosy by yourselves. So depending on the stage, the differentials will change. So I'll just run some pictures. So we saw hypopigmented patches in leprosy. What are the differentials? One of the commonest things we can see is Malassezia furfur, or Pityris versicolor. So we call it aluhang or themal in Tamil. It's due to this yeast called Malassezia furfur. They come with hypo or hyperpigmented patches which are scaly and dry, commonly on the trunk. But typically patients describe itching with sweating. And since this organism is around the hair follicles, they can have a perifollicular involvement, as you see in this picture. And it produces a chemical called azelaic acid, which bleaches the skin. That's why the hypopigmentation. And this cream is using in this most of these fairness creams and whitening creams. So basically, these ladies who apply whitening creams are applying essence of aluhang. Right? So this perifollicular involvement and itching you may not see in leprosy. Leprosy lesions are usually never itchy. Right? I know it's bad to say never in medicine, but in that case, it's often correct. So vitiligo, that's another common thing that can be mistaken for leprosy. And in vitiligo, it's due to autoimmune destruction of melanocytes. They are often depigmented rather than hypopigmented in established patients, but early cases might be confusing because they are more hypopigmented. In these lesions, the autoimmune destruction of melanocytes spares the hair follicles which have stem cells which differentiate to melanocytes. So often they have a in the lower picture you can see vitiligo, where the perifollicular sparing of pigment, in contrast to aluhang, where there is perifollicular loss of pigment, like I said before. So this can help you to distinguish vitiligo from pityriasis versicolor as well. Right? It's like a mirror image. Another rare condition, but it's very important not to miss. In our clinics, you see 1 or 2 patients per year. A condition called mycosis fungoides, or it's a cutaneous T-cell lymphoma. Often these patients are mistaken as aluhang or leprosy. They come with these hypopigmented patches. Rarely they may be anesthetic, but not usually. It's usually in double covered areas like the buttocks, which can also be affected in leprosy. But also they have preferential involvement of the groin, axilla, which we usually never see in leprosy, right? So if you treat a patient for pityriasis versicolor, hypopigmented patches not clearing, please do refer. It might be a cutaneous T-cell lymphoma rarely. So some more pictures of that. You can see demarcated hypopigmented patches. So please refer, especially if there's buttock involvement in lesions like this. Pityriasis alba is a common condition we see in children with hypopigmented macules on the cheeks. It's often associated with eczema. They are also dry patches and they are usually not anesthetic. But in younger children, it's a bit difficult to check for anesthesia, so it can be challenging. It's often seen in the sunnier months and can be associated with eczema. Polymorphic light eruption, again seen with sunlight, often in months of April. These children give a history of being in the band or doing the march past or swimming, and often you see it in April, May, right? And they are itchy, so that helps to distinguish. Another common condition we see in young adults is what we call progressive macular hypomelanosis. It's asymptomatic, but it's not. It can look like pityriasis versicolor, but it's not scaly, and it typically involves the midline of the back, which we don't see in leprosy. The cause is not exactly known. It's thought to be a reaction to the acne organism. It's called QT. It's Propionibacterium acne. It's given a new name these days, but it's due to that. But if you use a Wood's lamp, we can distinguish from leprosy. Sometimes you might see certain birthmarks, which can be mistaken for acne. They have bizarre jagged edges. And if you ask the history, these are often they are from birth, unlike leprosy. Tinea is another condition which is very common. You can see scaly patches. So these often come with red scaly patches, right? So this is a differential for red scaly patches of leprosy, but they are itchy and often involves the groin. And they come over shorter period, like weeks to months, unlike leprosy, which takes months to years. And often these are quite itchy and involves the groin. Tinea also can involve the earlobes. So again, another tricky area. And earlobes may not be that itchy as well. And they can coexist. So this patient came to us with a itchy rash on the forearm. You can see the red patches, which are due to tinea, but we noticed him to have a hypopigmented anesthetic patch in his arm, which is actually leprosy. So both can coexist as well. So don't miss. So urticaria again come with red patches, right? But these are very itchy usually, and they are very transient. They change over days to hours. So you can easily distinguish from red patches of leprosy. Atopic dermatitis can come with either white or red patches, usually after 4 to 6 months of age. Can be itchy, but obviously little child can't tell you it's itchy. And they can be dry. And it commonly involves the scalp and the flexures, which we usually don't see with leprosy. And leprosy is usually commoner in very young children because it takes, as I said before, a long time to develop the clinical manifestations. So it's unusual in infants. Again, chronic plaque psoriasis can come with red scaly patches, but they might have nail changes and the scale is very silvery, and they can also have arthritis and scalp involvement. Now, cutaneous leishmaniasis again can come with ear involvement, which can be tricky with leprosy, because leprosy also can come with ear involvement, but they often are from endemic area, and the smear will help to distinguish. So leishmaniasis can come with ulcerative lesions and nodules as well, like in these pictures, so it can be a bit tricky. So nodular acne, as I showed in the previous picture of nodular leprosy, can be tricky, but these lesions can be associated with comedones, which are only seen in acne, and these are more transient. Moving on to treatment. So obviously, treatment is not just the anti-leprosy treatment. The management of leprosy is much more broader. We'll see about that in a little while. But broadly speaking, specific leprosy treatment, we use multiple drugs to prevent resistance. And from a therapeutic perspective, we divide all these patients into multibacillary and paucibacillary, right? And it's a multidisciplinary approach. So depending on this number of skin lesions and the smears, and if there is no involvement of nerves, thickened nerves, we treat with the paucibacillary regime, which is usually just for 6 months. But if they have a lot of lesions, larger lesions, and even with one nerve involvement with positive smears, we go for the multibacillary regime, which is more intensive, and for 12 months, sometimes even up to 2 years, right? That is 24 months. So you can see the paucibacillary cards at the top. These are provided free of charge by the WHO. So the first day you get 3 tablets, and on the other days you get just 1 tablet each, right? In the paucibacillary regime, the one on the left is for adults, right is for children 10 to 14 years. And lower down you get the more intensive regime, which is given for 1 to 2 years for multibacillary patients, where you get 2 drugs daily, and on the first day you get much more. So we give rifampicin once a month and clofazimine and dapsone daily for multibacillary, and for paucibacillary, rifampicin once a month and clofazimine daily. So not just drug treatment, specific drug treatment, we use other drugs, especially for reactions, for pain, we give NSAIDs, we give steroids for reactions, then other drugs like thalidomide also have a role, especially in reactions. I'm not going to those right now. Physiotherapy has a major role in leprosy, especially, in patients with deformities and disabilities. We give them a lot of exercises, and then they are given splints and orthotic devices, and especially to assess the response to treatment and even post-surgery to assess, for their rehabilitation as well, we use physiotherapy. So we use splints. I'm not going to a lot of detail. So there are many different splints we provide, depending on the paralysis and the disability, right? Then for foot drop, there are separate splints. And most of our patients with peripheral neuropathy, we give them special shoes with micronized crystalline rubber to prevent damage. So these are similar to the shoes used in diabetic neuropathy as well. And these are provided free of charge every 6 months to our patients who need it. So surgical reconstruction is also done. Now, usually, when there is any evidence of nerve impairment, which within 6 months we try medically by using oral steroids and immunosuppression. Over 6 months, the evidence suggests that immunosuppression is not of much benefit, and then you have to go for surgical reconstruction. So this is called a lasso surgery, where we used to treat, claw hands, and they can be quite effective. Unfortunately, we don't do this regularly due to lack of manpower and the resources. We are trying to establish it at the moment. So you can see how much the disability has been cleared. The claw hand has been cleared, and the patient can now clench the fist. So there are orthotic devices, when you have claw hand or lose your fingers, to help you eat. And there are so many other things we do provide for the patients. And when patients with amputations, permanent prostheses are provided as well. So I provided this slide with childhood leprosy for 2 reasons. One thing, obviously, they are going to be the future of our, workforce. So obviously, when they are affected, that affects our economy. And more importantly, as we spoke before, Leprosy has a long incubation period. So we don't know when we see new patients in our community when they got the disease, whether the disease is actively spreading in our community. So from an epidemiological point of view, if we have a new patient, we don't know whether they got it 20 years ago or 6 years ago or 4 years. But if you have a 2-year-old child with leprosy, he definitely got it within the last 2 years. So childhood leprosy is an indicator of ongoing active disease transmission in the community. So that's why epidemiologists pay a special role to childhood leprosy, right? So just, even if you forget everything else, this is just a summary I need you to have. So what will help you to suspect leprosy? So if they have a positive contact history, a household contact or a family member with leprosy, or the patient has a past history of leprosy coming with new hypopigmented patches, lesions over a few days to hours is unlikely to be leprosy. Months to years, yes, can be leprosy. Coming from an endemic area. So when we see a patient coming from Moratuwa, Ratmalana, Piliyandara, we have red alerts going in our brain. So then those areas, then sometimes Jayawardena, Purakolonna, Orugodavata, those areas we see a number of patients. So those are clues. An anesthetic lesion in our brain is leprosy until proven otherwise. Whether it's hypopigmented or erythematous or whatever, any new onset anesthesia or hyperesthesia is suspicious. Having cutaneous stigmata of leprosy, trophic ulcers of uncertain cause, neuropathic ulcers, then loss of motor function, foot drop, wrist drop, thickened nerves, especially now, thickened nerves can be seen in so many other causes. Diabetes, acromegaly, amyloidosis, neurofibromatosis, but irregular thickening of nerves is very, very suspicious of leprosy. Leprosy is unlikely if they are itchy, acute onset lesions, scalp, axillary revolt or groin involvement, and proximal muscle wasting is very unusual in leprosy with the absence of sensory symptoms. It's very unlikely to be leprosy. Proximal, because as I said before, it's mainly a peripheral disease. So what do you do if you come across a patient you suspect leprosy? So what we need you to do is to refer to the nearest hospital with dermatology services. Most base hospitals, almost all district general hospitals, provincial general hospitals, teaching hospitals, and national hospitals have dermatology services. So please refer the patients there, or you are more than welcome to refer them to me at the Central Leprosy Clinic at the National Hospital. Of note, you don't have to refer to the OPD, you can directly refer to our clinic, right? So the patient doesn't need to go via the MOPD. Also, in patients who can't come physically or for some particular reason don't want to come, they can always send us a picture on this WhatsApp number. It should be clear and they should give a brief history. But of course, this is very subjective, depends on the patient's quality of picture taking. But and sometimes we have to get the patients down when we can't exclude leprosy by the picture. And also, if you need further information, you can contact your local public health inspector as well. So thank you very much. So you can ask any questions if you have any.
Thank you.
I hope
Thank
it
you
was
for that
clear.
insightful, informative lecture, sir. So we have a few questions on the chat box. The first question, I think, to rephrase it, they're asking whether the nerve thickening can only be seen in tuberculosis leprosy. I think that's what she meant.
Yeah, actually it's like this. So as I said, it's the inflammatory response, the inflammation that causes the nerve swelling in tuberculoid leprosy. So that is more towards the tuberculoid and the borderline tuberculoid pole, where you get one nerve very thickened, tender, with loss of function, nerve palsy in one nerve, very thickened, very obvious thickening, right? So it might be associated with the patch. But when you go to the other pole, lepromatous leprosy, now that there is not much inflammation going on, but the bacilli infiltrate the nerves. So nerves get the nerves can be thickened, but that's not one nerve. There are multiple nerves, can have both ulnar nerves, then the sural nerves, common peroneal nerves, but they are not as marked as in tuberculoid leprosy. And unlike one nerve, this is like a peripheral, symmetrical nerve thickening, right? And not very marked. You won't, because that's due to the nerve infiltration by the bacillus, whereas the former is due to inflammation and nerve swelling, right? So that's one nerve, but here it's multiple nerves and not as marked. I hope that's clear.
Thank you, sir. And another question has been asked on incubation period of leprosy. I think sir already commented on that. And also, Madam has also dropped in a comment. She has said that it averages around 3 to 5, but can have an incubation period of 10 years, sometimes even 20, as you told, sir.
Yeah, that's absolutely true. So the importance of this is now, when we treat a leprosy patient, we obviously screen the family members also, right? Now, when if we see a patient today, the patient completes the treatment in 6 months or 1 year, we get the family check, no one has leprosy, we reassure and send. But 4 or 5 years down the line, 10 years down the line, they might come with leprosy because obviously, it takes a long time to develop. So that's why we do serial screening, and also we advise the patients, please, if you get any new patches or any family members get any new patches, whatever stage, even if it's 10 years or 15 years, you need to get that checked, because to get the clinical manifestations, it takes time. Now, the important thing is, once you start the treatment, within the first week of treatment, more than 95% of the organisms are dead. So you won't spread the disease. Even if you are lepromatous, it's very unlikely, unless you default treatment and the disease comes back again.
And another quick question, sir. They have asked, is there any difference for treatment between borderline leprosy and lepromatous leprosy?
Now, usually tuberculoid leprosy, now all those what I showed you is what's given by the WHO, which is practiced in many countries where they don't have access to dermatological care, where just like a public health inspector, someone just counts the number of patches, it's just 3, so it's possibacillary, it's 10, so it's multibacillary, right? But ours is a small country, so we have access to dermatology services, so we don't just go by the number of patches alone, right? So if it's even one patch, if it's a very large patch, ill-defined margins, right? So even borderline tuberculoid, sometimes we would go for multibacillary treatment. Whereas if it's a small patch, well demarcated, just one or even two, we would go for paucibacillary, right? So all that borderline ranges, except for maybe one small borderline tuberculoid patch, where it's having ill-defined borders, but a small patch, we do a smear, there are no bacilli, just one tiny patch. Even if it's borderline tuberculoid, we might give paucibacillary. So borderline tuberculoid is kind of like the cutoff, right? But even then, if it's a large patch, you would still go for multibacillary.
I have a question myself. So, a- as healthcare workers, like, are we, now since we are more exposed to people, are we in risk of getting leprosy than the general population? And since you told us that it is spread via air droplets, can a normal 3-ply mask prevent the healthcare workers from getting the leprosy?
Well, first and foremost, this is spread by droplets. So obviously, even if you wear a mask, it'll catch most of the droplets. But having said that, this is not a very virulent disease. So you have to have repeated exposure over a long period of time. Now they say, on average, you have to have 8 hours of exposure to a multibacillary untreated patient, um, 8 hours daily for 5 days. That's roughly 40 hours a week for 3 months continuously to get the disease. Obviously, I don't know how they found that out, but that's what they say, right? So you can see, and even then, depending on your cell mediated immunity, as I said, only if 100 are exposed to those circumstances, untreated multibacillary patient who is with you for 3 months, at least 8 hours a day, still only 5 would get it. So you get an idea why it's very unlikely that you'll catch leprosy from a patient. You usually won't, right? Because most of the patients in our clinic are treated. So just because you meet someone for 10 minutes or 15 minutes at the clinic, it's very, very unlikely. You won't basically get it, right? Certainly not from patients who are on treatment, because obviously, as I said, within a week's treatment, they don't excrete bacilli with their saliva.
So I think we can make this as the last question for the day. It has been asked where the smear testings will be available.
Usually they are available at any dermatology clinic. Most dermatology clinics have, but there is a bit of a practical issue because some dermatology clinics, we don't have much MLTs these days. Some have migrated and things like that. But and there are certain issues about, it's quite subjective, one MLT doing a smear may not be identical to another one. But usually the smears done at the central leprosy clinic are pretty accurate, and most dermatology clinics do have that service. Right. So I didn't tell you all much about the smears, but just for your knowledge, what they do is they take a bit of tissue fluid, use a blade to slit through and get the tissue fluid. We don't want blood in the liquid, so we have to pinch the area properly. So we take it from the earlobes, nose, and from the skin lesions, and we rub it on a slide, let it air dry, and we use special stains, acid-fast stains, and we look. So we might see live bacilli, or we might see dead bacilli. There are ways we distinguish. If the bacillus looks granular or short, it's dead. If it's uniform length and not broken, then we know it's live. So it's given in a logarithmic scale, right? So we give like +1, +2, +3, +4 like that. So +4 has 10 times more bacilli than +3, like that, so on and so forth. And so they also give a morphological index, that is what percentage are alive at the time of staining, right? So it might be 5%, 10%, 20%. So the higher the percentage of the morphological index, the higher infectivity of the patient. Now, our target during treatment is at the end of the treatment, all patients, multibacillary patients, the morphological index should be 0. There shouldn't be any live bacilli. But dead bacilli will be there because they take a lot of years for our immune system to clear even the dead bacillus, right? So even sometimes you might come across a report where it says BI, or the bacillary index is +2, +1, but we are not treating because we have already treated and the morphological index is now 0.
Okay, thank you so much, sir. So I think it is time for us to wrap up this session tonight. I would like to thank the speakers again and also the attendees. And people have asked whether the recordings will be available. Yes, definitely it will be published in the social medias of the College of General Practitioners of Sri Lanka. And thank you so much for joining. I'm Dr. Harun Taufik. Good night. Thank you.
Thank you. Good night.